So thank you everyone and welcome to today's webinar. And the topic of today's webinar is personalized musculoskeletal modeling to predict total knee arthroplasty mechanics from clinical input data. My name is Christopher Iversen and I'll be responsible for the sales and marketing efforts here at Anybody Technology. And today I'll be the host of this webinar and I'll be assisted by my colleague Björn Engelund during the Q&A session in the end. In the Anybody webcast series, we feature a variety of presenters who have utilized the Anybody modeling system in different applications. And in today's webcast, I'm very pleased to introduce our speaker, Malte Asseln, who is an assistant professor at the University of Twente in the Netherlands. And Malte will present a personalized musculoskeletal model suitable for predicting TKA mechanics based on clinical input data. And rather than personalizing a full body model, Malte and his colleagues built a lower extremity model from scratch, based solely on input data available in routine clinical practice. And the paper covering this work is actually already published. So if you want the very details of Malte and his colleagues' work, then you can find it online. And the presentation will start in a few minutes, but just before we start, I'll give you a general introduction and overview of the Anybody modeling system, if there's any of you who are unfamiliar with the software or musculoskeletal modeling and simulations in general. First of all, I would like to draw your attention to the control panel. It appears on the right side of your screen, and you are very welcome to submit questions and comments via this question panel during the presentation. We'll try to do our best to address all of the questions at the very end of the webinar, but in case we do not get to answer all of them, we'll try to do so by email within a reasonable time. So let's begin with having a look at what the Anybody modeling system actually is. Well, the Anybody modeling system is a software that allows you to do musculoskeletal modeling and simulations. As input, it takes motion data as kinematics and forces, and it calculates the internal body loads as joint reaction forces, and muscle activity, and metabolic energy in some cases. And at the moment, Anybody is used in a wide variety of areas and applications. And to give you a few examples of this, it could be movement analysis, it could be product design and optimization, could be the field of sports optimization, orthopedics and rehabilitation. We do a lot of ergonomics with and without assistive exoskeletons, as for example, and we are also widely represented in the automotive industry. To give you an idea about the typical workflow in Anybody, it could look something like this. So you provide the recorded motion data as input, and you use the body models which you or others has built. You can then provide some kind of environment, which could be with a special type of equipment, for example, an exoskeleton. And you can then use Anybody to combine these things, solve the muscle recruitment and run the inverse dynamic simulation. And this basically means that we go from motion to calculating the internal body loads and the interaction with the environment in some cases. You can then output the result and use it for some kind of post-processing, which could be with, for example, a final element tool. But there's also many users who choose to complete this loop by doing some kind of design optimization and then run this cycle multiple times. And this actually brings me to the end of the introduction, so I will hand over the presenter role to Malte instead.
Thank you very much, Christopher, and to the whole Anybody team for this invitation and also opportunity to present our work. Also, I would like to give a warm welcome to all viewers joining us online for this webcast. And I hope we can give another nice orthopedic example how the Anybody system can be used. Before starting with the actual presentation, I would like to emphasize that this work essentially originates from my PhD, which I did at the chair of medical engineering at Aachen University. So special thanks to my promoter, Professor Klaus Rademacher, and also to Sonja Ehreiser, who later continued this work and also took the initiative in writing this recently published article. So I assume that the audience is quite familiar with total knee arthroplasty, but let me give you a short introduction. So in short, TKA, and this can be considered as a highly successful procedure and a gold standard to treat knee osteoarthritis. So it relieves pain to the patient and enables mobility again. So the demand for TKA has risen substantially over the past almost 2 decades all around the world. And if we look at the predictions, and here in the example of the United States, there's an expected tremendous increase, especially compared to total hip arthroplasty. However, if we look at for example, the satisfaction rate, so this is rather low. So these data is historically older, so it has been reported that 1 in 5 patients are dissatisfied, and in publications from the recent years, there's indication that this slightly increased, but in a new meta-analysis, I read it for this webcast, it was stated that there's dissatisfaction of 10%, but they used a much more conservative approach how to judge dissatisfaction. So nevertheless, we can state that a high proportion of patients are dissatisfied due to insufficient pain relief, limitations in physical function, and complaints, and also unmet expectations. So to summarize, the encouraging results were provided here, involving arthroplasty, but still poor functionality and satisfaction. So let's take a bit deeper look together how such a TKA is actually planned and executed. So normally a preoperative imaging is done, and here you can see a so-called scout image. So the patient is in supine position, and we get an overall overview of the lower extremity. So to identify certain body regions, such as here the hip joint, the knee joint, and the ankle joint region, to do high resolution scans. And these high resolution scans can be used for 3D reconstruction. Here in the example of a patient with a 6 degrees valgus deformity, and that's the pre-op situation. And this can be used during virtual surgical planning to plan the implant. Normally, then the leg axis is corrected, and here in the example, neutral alignment. So we establish a full leg, depending a bit on the philosophy of the surgeon and the clinic. And we also define then the cuts, how then the surgery is actually executed. However, if we look here at the biomechanics, so they are only considered indirectly. So this approach of establishing a neutral leg axis kind of considers that then the implant or the joint is loaded equally. So the compartments, which is of course favorably for wear and contact pressure. However, we see more asymmetric designs nowadays on the market, and this is not always ideal and deviates also from the anatomical situation. So there's also an ongoing debate whether this type of alignment is the right target. So, but not only in the preoperative, also in the intraoperative stage, biomechanics are not really considered, or only in a static or passive way. So what is usually done is that the surgeon manipulates the leg to test, for example, the ligament tension. We call it varus valgus first test, but also to entirely flex and extend the lower leg and see with a trial implant how the knee behaves. However, this is a quite artificial load case and not really representing active kinematics, which we know that they are substantially different from active kinematics acting in the knee. Also, about 90% of the forces are not really present in this unloaded intraoperative situation. So musculoskeletal models has here the potential to predict dynamic active interactions of the knee joint, and that was also the aim of our study. So to develop and evaluate an image-guided and model-based planning system based on personalized biomechanical models using the antibody modeling system. So what could be a general pipeline from clinical data to an actual biomechanical feedback? So typically in the hospital, a number of data is acquired. For example, anthropometric data. So this can be height, weight, or sex, and also medical images are taken. And nowadays, often a CT or an MRI. And as just explained on the previous slide, this covers the knee region. So we assume it to be plus minus 15 centimeters of the joint line, the hip joint center, and the ankle joint center. But let's be honest, so there's no motion data, so no interaction forces or ground plate forces, and there's no muscle activity measured. But we think that this data is already sufficient to create a so-called, what we would like to call, geometric model. So we can use the medical image data to do a segmentation. And from this segmentation or segmentation mask, we can create a 3D reconstruction. This can be a polygonal mesh if we use, for example, a marching cubes, which we can then further process or apply already sophisticated algorithms, for example, for osteophyte removal. Then we can identify landmarks, bony landmarks, and anatomical coordinate systems, which is then often the basis for virtual surgical planning. So we define the cuts, the leg axis, and already virtually insert our implants. But we can also identify ligament attachments and muscle attachments based on a priori knowledge, which is also then part of this webcast. This whole geometric model can be then further transferred to a so-called biomechanical model to do actual biomechanical calculations. But then additional assumptions and modeling steps needs to be performed. So we need to actually model the joint, we need to model ligaments, muscles, and if we do inverse dynamic analysis, we have to feed the model with a kinematic and motion input and also with the loading conditions. And this biomechanical model can then deliver an output, and we can predict actual contact forces, the contact pressure, joint kinematics, forces acting on the ligaments and muscles. We can determine kinematics, and from this kinematics, make more reasonable calculations, for example, determine the rolling gliding, or also the rollback, such as the anterior paradox motion, something we would like to avoid in knee implants. And these outputs or predictions we can use to evaluate, for example, a pre to post-op situation. We can evaluate different implant designs. So this can be off-the-shelf implants or even personalized implants to find kind of an optimal implant shape, but also to optimize, for example, the alignment. So this was a more general overview from potential clinical data to biomechanical feedback. But now let's take a bit of a closer look and dive into the modeling workflow we applied in our paper. It's a slightly different arrangement, but similar steps. So we have initial patient data, the anthropometrics, for example, patient weight, and we can get knee surface models, and let's just presume for now that they are given. So because the segmentation can be nowadays easily solved. And we have additional a priori information we used, such as statistical shape models, which we annotated, and statistical motion patterns from literature, and which we then fed into a multi-body simulation, so the antibody modeling system. We used the patient weight to determine external forces, the knee surface models to define joint contact, so we used the force-dependent kinematic framework for that, and the statistical motion patterns we used to apply kinematic constraints to our model. So then, as already stated by Christopher in the introduction, our approach was not to personalize the full body model from the antibody repository. So we modeled for our patient from scratch. Outside of the antibody software, we did this in MATLAB, and then wrote transition scripts basically to then adapt this geometrical model or transfer this geometrical model into antibody. And we got a few simulation results. And in this presentation, I would like to focus on the joint reaction forces, which we also used finally for model validation. Of course, I cannot cover the entire process of the modeling, but I would just like to pick a few aspects. And one of them is the annotated statistical shape modeling. So we have been provided with segmented knee data from an industrial partner, which we used to calculate statistical shape models. So approximately 300 data sets of the femur and of the tibia. And for the patella, we used the data from a different study. So we annotated these statistical shape models with anatomical landmarks, here highlighted in blue, but also with ligament attachments visible in green and in red. And this resulted in annotated mean shapes, which we then later used as a template to propagate these landmarks onto new targets. And this is what we evaluated in a small study. So this is a conference paper you can look up. So we got cruciate ligament attachments from overall 6 patients. We used our annotated mean shapes and performed a leaf 1 hour cross-validation. And then we morphed. So we used a non-rigid ICP implementation for that, following Amberg et al. To do a non-linear transformation of this mean shape to a target shape. And thereby, again, we propagated the landmarks. And then we compared the results to the actual ground truth for all 6 patients. And we found differences between about 1 to 4 millimeters, with higher deviations for the anterior cruciate ligament, the ACL. But be aware that this is sacrificed in total knee and TKA anyway. So a quite precise approach, and also similar to other studies, what other studies reported in literature. Then we applied this morphing approach in our biomechanical modeling pipeline. So we had here in beige our target, in green our template, and performing then the morphing resulted then in the landmark propagation. And this is just exemplarily shown for the femur, but we applied it in a similar way to the tibia and also to the patella. And this is a short video showing how the non-rigid registration takes place. That's Amberg's implementation. So there's a so-called alpha value, kind of a stiffness weight, and this results in a gradual, so to gradually give up the rigidity of the model, so decreasing the stiffness weight, and thereby our template deform into the target. One thing I would like to mention here, which is not shown, that of course this only works for when we have surface models available. Very often in the clinical routine, for example, the fibula is not segmented and provided, as this is not really needed for the implant planning itself. So here we used an overall affine transformation and to estimate the attachments of the lateral collateral ligament, which attaches at the fibula head. So on top, we performed a knee joint processing as we had to introduce anatomical coordinate systems. And there's a very nice publication from Lee et al. Called Automating Analysis of the Distal Femur, and they proposed a computational framework to calculate a so-called unified sagittal plane. So there's also in literature a big debate how to define anatomical coordinate systems. And we tried different approaches, but this is what we found as a very robust method, really defining a sagittal plane by fitting ellipsoids into the posterior condyles. And this algorithm derives so-called cutting planes to fit these ellipsoids in the posterior condyles. And then an overall cost function is optimized to minimize the eccentricity of these ellipses. So in a unified sagittal plane, then these ellipsoids are almost cylindrical. So you can assume or interpret this algorithm as kind of an iterative approach, how to find the posterior condylar cylindrical axis. And this has also a functional relation, as we know that during high flexion, the knee performs mainly gliding, so around an almost cylindrical axis in the posterior condyles. So the authors didn't provide an implementation, but this work has been done by one of my colleagues, Maximilian Fischer, and this is publicly available in a GitHub repository, which you can access via the link below. And this unified sagittal plane we use then together with the hip joint center and also the epicondyles to define a transfemoral coordinate system. So this transfemoral coordinate system We then, in the next step, also used to identify a patellofemoral joint. So here we followed a publication by Coughlin et al., and they presented a relation between the patellofemoral and tibiofemoral joint. So we used the same axis alignment for both. So both coordinate systems are in parallel, but then just translated. And here we used the presented data. And further to set up our model, we had to identify muscle attachments. And we used a publication by Tanifuchi, who studied the pulling direction of the quadriceps muscle in 14 subjects. So they segmented muscles, determined then muscle pulling directions, and reported overall an overall formula how this is how the pulling direction is given with respect to the hip joint center for different axis systems. And this is then also what we implemented for our quadriceps muscle, what you can see here in the right picture. And these aspects of geometric modeling were basically then the input for our simulation model to simulate a squatting motion or knee bend, what you can see here at the right-hand side. So this is just a model of the lower extremity. We modeled the quadriceps and made it out of 4 parts. And we also added 2 hamstrings, but basically for stabilization, and they were assumed to provide a constant force to the knee joint. So a minimum co-contraction. Then we set idealized boundary conditions. So a load applied related to overall body weight, which we estimated from anthropometric data. We modeled the knee using force-dependent kinematics, so that it moves as a function of external forces, ligament forces, and muscle forces. And we set all degrees of freedom. We allowed all degrees of freedom, so 6 for the tibiofemoral joint and 6 for the patellofemoral joint. And in our knee model, we overall used 19 ligaments, and we used standard literature data for that. So we modeled them as being non-linear elastic and time independent. To be a bit more realistic, we also incorporated wrapping surfaces, and these were calculated within any body in a parametric manner. So we added a wrapping cylinder for the quadriceps muscle, and we forced the long axis to be parallel to the mediolateral tibiofemoral axis, and the radius was calculated as the distance between the femoral notch point, and this was implemented in our annotated statistical shape model and the actual long axis. And then we added a second cylinder, a second wrapping surface for the medial collateral ligament, and this was forced to be parallel to the anatomical tibial anterior posterior axis, and we set the diameter as half of the mediolateral image. So here was no manual adjustment needed. Here you can see it in the left image for the initial position and the center image after in our calibration position. So when calibrating the ligaments and the muscles, and then on the right hand side in the deepest position of the knee bend. Now I would like to talk about the kinematic constraints we used to simulate the squatting motion. As all of you know, for inverse dynamic analysis, we need motion as an input, and we wanted to be independent of any kinematic analysis, as this is typically not available in clinical routine. And we found a nice paper by Wong et al. From Leuven, and they presented a nice study on in vivo 3-dimensional lower limb kinematics doing high flexion squats. And what they did for overall 17 subjects, they went into the gait lab, they measured squatting motion with an optical tracking system, and then they tracked the ankle joint center and the hip joint center and their relative positions indicated here by AP, so anterior posterior, and HH, so hip height. And they presented some nice graphs. So here the left one, you can see how the hip moves relative to the ankle for a descent and for an ascent as a function or as a percentage of overall leg length, so the length of the femur plus the tibia. And during descent, you can see that hip height decreases, which makes sense, and during the ascent, it increases again. In the anterior-posterior direction, so the hip joint moves posteriorly while descending. So here it is at rest in the deepest position, and during ascent, it moves anteriorly again. And interestingly, the mediolateral relative position is constant over squatting cycle. So they also reported what you can see here in the right figure, then how the hip center and ankle center move relative to each other in AP direction, and also applied kind of a polynomial fit and also an ellipse fit to describe this relative movement, and also presented a formula how this can be estimated. So from this study, this is what we implemented in our antibody model. We took these two main findings, that medial lateral position of the ankle was nearly constant over squatting, and that it stays lateral, so the ankle stays lateral to the hip, and that also the ankle was more anterior with lowering the hip height. And this is what you can see here in our initial positioning. So in the sagittal and frontal plane, let's assume we have a global reference frame where X is in left-right direction, Y points in cranial-caudal direction, and Z in anterior-posterior direction. And for the knee joint, we defined the coordinate system according to ISB recommendations. So X pointing in medial lateral direction, Y in anterior-posterior, and Z proximal distal. And then we forced the ankle joint center to be in the global origin, and the hip joint center in the initial positioning, so at time point 0. So the anterior posterior was set to 0, which you can see in the left image. So the hip joint center is right above the ankle joint center, and we use a constant in mediolateral direction. So that's indicated here by the X component at time point 0. And then it has an initial height Z due to the leg length. To fix the orientation around the long axis, we set then the sagittal, unified sagittal knee plane we previously calculated to be orthogonal to the frontal plane of the global reference system, so to the XY plane. And then for the motion, for the actual motion analysis, we simulated the squatting, where we described, based on the data provided by Wong, the hip joint center position, how it moves with respect to the ankle, so that it moves posteriorly over increasing flexion, and also then hip height decreases in the mediolateral direction. We set the hip joint center to be constant. So, but now let's take a look how it actually looks like in the simulation. So this is our squatting motion in different perspectives. So you can see how the soft tissue structures are wrapping around the cylinders and how the quadriceps become active, but also then how our squatting motion overall looks like based on the kinematic constraints we added. Here's in the hip joint. So with this red arrow, we have indicated a vertical load we applied. And again, we took here the percentage based on the anthropometric atlases as a fraction of the body weight. So we created a biomechanical model of the lower extremity, just working with data available in the clinical routine. But how valid is this whole approach? So we followed, where possible, literature assumptions, but we actually used an in vivo data for a false validation. I think also the people in the audience who deal with biomechanical modeling of the knee are well aware of the so-called Grand Challenge competition. So this is a competition by Fragli et al., who provided in vivo force measurements from instrumented tibial implants, along with all kinds of clinical data, such as pre-op CTs, post-op CTs, implant geometries, and then the actual force measurements and motion data. So this is a very nice data set, and up to now there are data sets from 6 competitions publicly available, which you can download from simtk.org. What you can see here in this tabular overview in the right column, so that they had came up with actually 2 implant generations, and for our validation study we decided to just work for now on the newer implant, so the 2nd generation. So we processed the provided data and then modeled all 4 patients we considered, so from Grand Challenge Competition 2, 3, 5, and 6. And then we ran our simulation. So, and here are the results. So looking at the first column, we see Grand Challenge Competition 2. In the left image is the medial contact force, in the center image the lateral contact force, and in the right image the total contact force. And annoyingly, here we are already a bit off. But on the other hand, if you look at Grand Challenge Competition 3, and you can see it for all trials, 4 trials in total, and green the mean. So our simulation covered quite well the in vivo data. But also what I would like to highlight here is the load curve of the experimental measurements, which I would like to address in a minute during the discussion. But first, let's take a look also at Grand Challenge Competition 5 and 6. So for 5, we see that we can capture quite nicely, again, the in vivo forces. And for 6, the magnitude on the lateral side seems fine, but then for the total contact force, is also a bit off again. So what if we look at the validity of the experimental data and compare it to other in vivo measurements which are available from the Bergman group in Berlin? And they have reported it here in a nice publication, highly cited, of 5 patients, so that you can see that for almost all of them, for an increased squatting motion, also knee joint forces increase, which is also makes completely sense. So we have an increased muscle activation, which should lead then to higher knee joint forces. And in this study, we can see that if this trend is also seen in the experimental data, our simulation captures this quite well. But if this is off, so then we also see a difference then between experimental data and our simulation. But we are also very critical, and if we compare ourselves then to previously published studies and compare our accuracy in terms of root mean squared error, and here we have listed almost seven other studies, we can see that our prediction accuracy is quite well. So most of the studies presented in literature focus on gait, and there are just 2 other studies focus on squatting. So then the number of patients or participants in the study is almost quite low. And here also we included all Grand Challenge competitions using the 2nd generation implant. And then if we look at the differences, so here we have a range, we have a total root mean squared error of around 42% body weight, and this is in the same range, or in some cases even lower compared to other literature. And also we indicated our range here, and if we would take our best cases, then it would be even more accurate than previously reported. What I would also like to highlight is the simulation time. Very often this is not reported, but this is also a critical aspect towards clinical implementation. And our squatting motion or simulation time took less than 4 minutes, which is much faster than before. And this we think originates from the simplified setup, but also we selected, we remeshed our implant components and identified a certain density, which gave us a good trade-off between computation cost, but then still a good contact behavior. So coming to the conclusion and outlook of this presentation. So our model offers the opportunity to predict and study knee joint mechanics. Our model generation process is almost fully automated and just rely on the data which is available in the clinical routine. So we need CT or MRI of the knee joint region, the ankle and hip joint center. So on this we can determine the mechanical leg axis, and we need anthropometric data, so body size and body weight for our relations for the loading, but also for our kinematic constraints. Keeping the results in mind I just showed, I think we can state that we were able to predict in vivo knee joint forces in a similar accuracy as previously in literature, but just with a minimum of input data. And what we see towards clinical integration in the future are then advanced sensitivity studies, as lots of assumptions haven't been in-depth verified. So then a target definition. So what is then an optimization or potential cost function, assuming that we can robustly and reliably predict knee joint mechanics, and then an overall evaluation of time and cost efficiency. And with this, I'm at the end of my presentation. So thank you very much for your attention. And then I'm very happy to take your questions.
Thank you very much, Malte. Just before we go to the Q&A session, I would just like to say a few words myself. So there we go. Yeah, so thank you very much for the presentation. And as I said, just before we go to the Q&A session, I would like to say a few words about our online resources and also upcoming events. So if you want to know more about Anybody Technology, then you can go check out our website, anybodytech.com, sorry. And here you can find all of our special dates, different events, and all of our previous webcasts. You can also check out our community website called anyscript.org. And this is really the page for people using Anybody. So there is our wiki page, there's several blog posts, and also links to our repository sites. It's also here our forum is located, so if you have some questions, you can go and get help from some fellow Anybody users. Then we have a couple of events I would like to highlight. So on June 10th, we host another webcast called Optimizing Fracture Healing, Realistic Boundary Conditions. This is Anne-Christine Andre from the University of Saarland, who will present her work on personalized simulations with a central role of realistic patient-specific boundary conditions via musculoskeletal simulations. This is based on motion capture data of patients with lower and upper extremity fractures. And the registration for this webcast is already online, so if you would like to attend or just get an email with the recording of the presentation, then please go to our website and register already. And then I would also like to mention that Anybody Technology will be present at the Congress of the International Society of Biomechanics in Stockholm, Sweden, here in late July. And I know many of you are attending this Congress, so please stop by our booth there and say hi. Then I would also like to mention that Anybody Technology maintain a publication list of papers using the Anybody modeling system. And this list is publicly available on our website, and it has reached more than 1,000 publications. So it's really a great place to go and look if you want to get some inspiration on how Anybody has been used in different industries. And I think this brings us to the Q&A session. So I'd like to thank you for your attention so far, and then we'll take a few questions from the audience.